Hello everyone, this is Kevin Young presenting a case study on calcific aortic stenosis.
Hi Kevin, thank you for your PowerPoint on calcific aortic stenosis. I found it very informative. One thing that really stuck to me was how you mentioned it's important to assess for heart murmurs whether it's low or high sounding and how that can make a difference in diagnosing aortic stenosis. Um, your explanation on the anatomy of the aorta was also informative because it allowed for me to see like the differences between like a normal aorta and a calcific one and how that can affect and how that can cause aortic regurgitation. So again, thanks.
In this case study, a 70-year-old man came to the hospital because of chest pain. He described feeling weak and dizzy after walking around the block. This episode of dizziness was followed by 10 to 15 minutes of chest pain that quickly resolved when he rested. Now, this is not the first occurrence of chest pain, as he describes a 2-month history of similar but shorter episodes after working in the yard. Several years ago, he was told that he had a slight heart murmur but had not been evaluated further. He has otherwise been healthy all his life. Physical signs and auscultation suggested aortic valve narrowing. The lungs were clear to auscultation, and the chest x-ray showed an enlarged heart with vague calcifications at the base of the heart in the region of the aortic valve. Cardiac enzymes and other labs were normal, but the ECG showed AFib and left ventricular hypertrophy. I'd like to point out that when a patient presents with chest pain, it is an immediate concern because it could be myocardial infarction. Even if the symptoms don't necessarily point to an MI, you must rule out the most serious first. This is why cardiac enzymes were drawn and an EKG was most likely done. So it was determined that this man had calcific aortic stenosis, and his valve was replaced, and he did well for several years, but then developed signs and symptoms of aortic regurgitation. Let's review and examine some anatomy first, before discussing how these tests brought us to calcific aortic stenosis. The aortic valve is located between the left ventricle and the aorta. It is the last valve blood passes through before entering systemic circulation. Another important piece of anatomy to point out is that the left ventricle is more muscular than the right ventricle, which is anatomically normal, but it becomes a problem when the left ventricle gets overworked and the muscle becomes bigger. On the right are two pictures of the aortic valve. The top picture is a normal valve that would function properly. The bottom picture is a calcified aortic valve with stenosis. Calcification is a deposition of calcium salts along with smaller amounts of iron, magnesium, and other mineral salts. In the aortic valve, this commonly occurs because of damaged or injured localized tissue, with calcium levels in the blood remaining normal. This type of calcification is known as dystrophic calcification. The stone-like bumps called calcific nodules can be clearly seen in the bottom picture compared to the top. Stenosis, by definition, is a narrowing. In this case, a narrowing occurs in the aortic valve due to the added calcification. It makes the valve more stiff, keeping it from opening up as much as it should. The symptoms that developed in our patient that pointed to the diagnosis of calcific aortic stenosis are chest pain with exertion that is relieved by rest. This is otherwise known as stable angina. Dizziness with exertion, enlarged heart, or cardiomegaly with left ventricular hypertrophy, heart murmur, and atrial fibrillation. Chest pain occurs when your heart does not get enough blood supply. This could happen for a number of reasons. In our patient, it is very important that it is relieved after rest. This means that the heart is not completely blocked from getting blood. So it could either be partial occlusions in any of the coronary arteries, or it could be a mechanical dysfunction of the heart, which in this case is a dysfunctional aortic valve. The dizziness with physical exertion also points to the aortic valve dysfunction, because the dizziness means that there is a lack of blood flow to not only the heart but also the brain. The lack of blood flow is now looking more like a systemic issue. The aortic valve acts like a door between the heart and the rest of the body. The only way your body can get blood is by opening that door. With aortic stenosis, that door is only being opened halfway, which incredibly limits the amount of blood that gets to the rest of the body. And because this passageway becomes smaller, the ventricle has to work harder to get that blood to the body. This leads to the left ventricle developing more muscle, making the left ventricle and the heart itself enlarged. A heart murmur is a sound of blood flowing through a passageway. In this case, it is signaling that the blood is abnormally flowing through the aortic valve. This is an important assessment with patients that have aortic stenosis in determining the treatment and likelihood of valve replacement, as we will discuss later. Atrial fibrillation is a common arrhythmia, especially in elderly patients. This should be taken into consideration because it could affect the prognosis and the treatment plans for this patient. As I mentioned before, there is a great importance in listening for heart murmurs in patients that come in with aortic stenosis. A Norwegian study followed about 2,014 patients over about 21 years. The study found that patients with soft murmurs had a 5-fold increase in risk of aortic valve replacement, and patients with loud murmurs had more than a 100-fold increase in aortic valve replacement. This becomes vitally important because hearing a loud murmur can become a very serious and perhaps life-threatening situation. This patient should be referred immediately for a possible valve replacement. Another recent study examined the link between a gene marker identified as RS1205 and aortic valve calcification. The gene allele RS1205 has been associated with lower levels of CRP, or C-reactive protein, which is a marker for inflammation in the body. However, this study showed the opposite effect among patients with aortic stenosis. The gene actually made CRP levels increase in the body, and the gene was also linked to larger aortic valve calcifications. This finding could potentially be a genetic risk factor for aortic stenosis and can be used to identify and diagnose the disease earlier on. The last study I wanted to share addresses this patient's recent onset of aortic regurgitation after his aortic valve replacement. Aortic regurgitation has a relatively high incidence rate among patients that have undergone transcatheter aortic valve replacements. It has been shown to have a negative effect on patient outcomes. A recent research article highlighted the importance of recognizing this complication early and proposed the use of tests that would actually normally be used for checking von Willebrand disease. And the study had promising results that closure time with adenosine diphosphate could be used as early detection of post-procedural aortic regurgitation.